Hello everyone, now let us discuss about 2023 ICD NCM coding guidelines for Chapter 6, which is nothing but diseases of nervous system. Chapter 6, there are mainly two guidelines. The first one is regarding the dominant and non-dominant side. Certain neurological diseases, they are categorized based upon the dominant or non-dominant side. The next is pain codes, which come under the category G89. Coming to dominant and non-dominant, codes from the category G81, which is nothing but hemiplegia and paraplegia, and subcategories G83.1, which describes monoplegia of lower limb, G83.2, which describes monoplegia of upper limb, and G83.3 describes monoplegia unspecified. So these codes which come under the category listed here identify whether the dominant or non-dominant side is affected. Should the affected side be documented but not specified as dominant or non-dominant, and the classification system does not indicate a default, code selection is as follows. Usually we have two sides, right side and left side. And if the site is documented, laterality is documented and it is not specified whether it is dominant or non-dominant. In such case, for ambidextrous patients, the default should be dominant. Either it is right or left. For ambidextrous patients, the default should be dominant. Next, if the left side is affected, the default is non-dominant because we consider majority of the people are right-handed. If the left side is affected, the default is non-dominant. And if the right side is affected, the default is dominant. Let us see here, dominant and non-dominant sides. For ambidextrous patient, any side you should code only dominant code. And for left side, and if the left side is affected, and if it is unclear whether the patient is right-handed or left-handed, then by default you need to code non-dominant side. And similarly, if right side is affected and we don't know whether the patient is right-handed or left-handed, and they did not specify whether it is dominant or non-dominant, then by default you need to code dominant side. By default you need to code non-dominant for left side, and by default you need to code dominant for right side. For ambidextrous patients, because they use two hands with equal dexterity, you have to code only dominant, whether it is right or left. Let us see example. For example, let us take one code, G81.9 series. G81.90, it indicates hemiplegia unspecified affecting unspecified side. Whereas G81.91 indicates hemiplegia unspecified affecting right dominant side. G81.92 indicates hemiplegia unspecified affecting left dominant side. G81.93 indicates hemiplegia unspecified affecting right non-dominant side. And G81.94 indicates hemiplegia affecting left non-dominant sides. So these are the various codes for one particular hemiplegia unspecified. Let us see various scenarios here. A patient presents with right side unspecified hemiplegia, and it is not mentioned whether dominant or non-dominant. And it is also not mentioned whether the patient is right-handed or left-handed. So whenever right side is getting affected, by default you need to code dominant side. So the appropriate code here is hemiplegia unspecified affecting right dominant side. The code is G81.91. Second case, a patient presents with left side unspecified hemiplegia. Here also it is not documented whether it is dominant or non-dominant, and it is not documented whether the patient is right-handed or left-handed. So whenever left side is getting affected, by default you need to code non-dominant side. So hemiplegia unspecified affecting left non-dominant side. The appropriate code is G81.94. Next case, we'll see ambidextrous patient. An ambidextrous patient presents with right-sided hemiplegia. For ambidextrous patient, both sides you need to quote dominant only. So for right-sided hemiplegia, you need to quote hemiplegia unspecified affecting right dominant side. G81.91. And next case, ambidextrous patient presents with left side hemiplegia. You need to quote hemiplegia unspecified affecting left dominant side. G81.92. I hope you understood what is the difference between dominant and non-dominant. By default, whenever right side is getting affected, you need to quote dominant. And when left side is getting affected, you need to quote non-dominant. And for ambidextrous patient, both sides, they should be dominant only. Coming to pain codes which come under the category G89. So under pain category G89, there are several guidelines. First is general coding information. The next is pain due to devices, implants and grafts. The next is post-operative pain. The next is chronic pain, neoplasm related pain and chronic pain syndrome. Let us discuss guideline for each case. Now coming to general coding information. Codes in the category G89, pain not elsewhere classified, may be used in conjunction with codes from other categories and other chapters to provide more detail about the acute or chronic pain and neoplasm related pain unless otherwise indicated below. And if the pain is not specified, this is important point, if the pain is not specified as acute or chronic, or if it is not specified as post-thoracotomy, post-procedural or neoplasm related, do not assign codes from category G89. That is clear. Whenever pain is not specified as acute or chronic or post-thoracotomy or post-procedural or neoplasm related, then you should not assign codes from the category G89. A code from the category G89 should not be assigned if underlying diagnosis is known unless the reason for encounter is pain control, pain management and not the management of underlying condition. For example, patient is having chronic knee pain and patient is having osteoarthritis of knee. So here the condition is osteoarthritis, but patient is having chronic pain. If the reason for visit is pain management, if he comes for pain management, then only you need to code G89 series, G89.29 for chronic pain followed by osteoarthritis. But when the encounter is to treat the osteoarthritis, not the pain, then you should not use code from the category G89. G89 codes should be used from the category only when it is for pain management. And when the admission or encounter is for a procedure aimed at treating the underlying condition. For example, spinal fusion, kyphoplasty, a code from the underlying condition, that is vertebral fracture or spinal stenosis, should be assigned as PDX, and no code from category G89 should be assigned. As I've said earlier, when the reason for visit is encounter for pain management, then you can use code from the category G89. But when the admission or encounter is for a procedure aimed at treating underlying condition, example spinal fusion or kyphoplasty, a code from underlying condition should be assigned as PDX and no code from category G89 should be assigned. Now coming to guidelines where G89 codes are used as principal or first listed diagnosis. The category G89 codes are accepted as first listed diagnosis when pain control or pain management is the reason for admission or encounter. For example, patient with displaced intervertebral disc, nerve impingement and severe back pain presents for injection of steroid into the spinal canal. Here, they can be considered as PDX because the reason for visit is pain control by giving steroid injection. And the underlying cause of the pain should be reported as additional diagnosis if known. When a patient is admitted for, second case, when a patient is admitted for insertion of neurotransmitter for pain control, assign the appropriate pain code as PDX or first listed diagnosis. Third case, when the admission or encounter is for a procedure aimed at treating the underlying condition and a neurotransmitter is inserted for pain control during the same admission or encounter. A code from underlying condition should be assigned as PDX and appropriate pain code should be assigned as SDX. This is an exception when the admission or encounter is for a procedure aimed at treating the underlying condition and a neurotransmitter is inserted for pain control. Here, during the same admission or encounter, a code from underlying condition should be assigned as PDX and appropriate pain management code should be assigned as SDX. This is a case where codes from pain management are assigned as SDX, not as PDX. This is exception. So there are two cases when they can be assigned as PDX. First is if the reason for visit is pain control or pain management. And the next when the patient is admitted for the insertion of neurotransmitter for pain control. Here also the reason for visit is pain control. By default, if the reason for visit is pain control, then you can use G89 series codes as PDX. But when underlying condition is treated by a procedure, then the pain code should be assigned as SDX, secondary diagnosis. Now let us see an example. Patient presents with acute low back pain due to trauma. First, steroid injection. Here the reason for visit is pain management. He is having acute pain due to trauma and the location is low back pain. So first G89.11 acute pain due to trauma followed by M54.50 low back pain unspecified. Now let us discuss the use of category G89 codes in conjunction with site-specific pain codes. So codes from category G89 may be used in conjunction with other codes that identify the site of pain. The previous example is also can be considered. It also can be considered because the site there was low back pain and additionally we are using a code from the category G89. Here, for example, if the code describes the site of pain but does not fully describe whether it is acute or chronic, in that case also you can use both codes. One code for site of the pain and other code to indicate whether it is acute or chronic, provided the documentation is clear whether the pain is acute or chronic. And coming to the sequencing of category G89 codes with site-specific codes, it is dependent on the circumstance of the encounter or admission as follows. If the encounter is for pain control or pain management, assign the code from the category G89 as PDX, followed by code identifying specific site. For example, encounter for pain management for acute neck pain from trauma. So here patient is having acute neck pain from trauma and he comes for pain management. So PDX will be G89.11 acute pain due to trauma followed by M54.2 that is nothing but cervicalgia. Second case, if the encounter is for other reason except pain control or pain management and a related definitive diagnosis has not been established by the provider, assign the codes from the site-specific pain first, followed by appropriate code from the category G89. So, code assessment is based on encounter for management. So encounter, if the encounter is for pain management, then codes from G89 category will be PDX. And if the encounter is for any other reason except pain control or pain management, condition will be the PDX, or simply site of pain will be the PDX if the condition is not still yet diagnosed. Then followed by code from the category G89. Let us see an example. A patient presents for evaluation of his chronic bilateral knee pain. Pain has been becoming more severe lately, prompting the visit. Here, patient is having bilateral knee pain, but the underlying condition is still not diagnosed. The patient will be sent for further testing. Here, the patient will be sent for workup to assess the cause of bilateral knee pain. So here it is not the pain management. The reason for visit is not the pain management but assessing the underlying cause for pain. In this case, first you need to quote pain codes as PDX, that is M25.561 pain in the right knee, followed by M25.562 pain in left knee, then patient is having chronic bilateral knee pain. Then G89.29 other chronic pain as SDX. Because here the reason for visit is not pain management. It is for the evaluation of condition which is causing the pain. Next, coming to pain due to devices, implants and grafts. Pain associated with devices, implants or grafts left in the surgical site, for example painful hip prosthesis, is assigned to the appropriate code found in chapter 90, injury, poisoning and certain other consequences of external causes. And specific codes for pain due to medical devices are found in T code section of the ICD 10CM. Apart from these, you can use additional codes from category G89 to identify acute or chronic pain due to the presence of device, implant or graft. Whenever we are coding pain for device, implant and graft, first codes from T category, that is chapter 19, they will take PDX followed by other acute post-operative pain. G89.18 if the pain is acute, or other chronic post-operative post-procedural pain if the pain is chronic, G89.28. These two codes can be assigned as SDX, not PDX, whenever we are treating pain due to devices, implants and grafts. Now let us see an example. Patient presents with chronic painful right hip prosthesis. Here patient is having chronic pain due to right hip prosthesis, that is an implant. So the code would be, first code would be T84.84XA, pain due to internal orthopedic prosthetic device, implants and grafts, followed by G89.29 other chronic post-procedural pain. A indicates initial encounter. Here I did not mention. T84.84XA indicates initial encounter. Pain due to internal orthopedic prosthetic device, implants and grafts, initial encounter. Followed by other chronic post-procedural pain, G89.29. Now coming to post-operative pain. The provider's documentation should be used to guide the coding of post-operative pain, as well as section 3 must be referred, reporting additional diagnosis, and section 4, diagnostic coding and reporting in outpatient setting. The default for post-thoracotomy and other post-procedural pain not specified as acute or chronic is the code for acute form. This is important. The default for post-procedural, post-thoracotomy or other post-operative pain, if it is not mentioned whether it is acute or chronic, by default you need to code acute form. And routine or expected post-operative pain immediately after surgery should not be coded. Generally there will be a little pain after surgery. That should not be considered. The patient is having significant pain after a couple of days of the surgery, And whether it is, when it is not mentioned whether it is chronic or acute, you need to code acute form. There are two scenarios in the post-operative pain. The first case is post-operative pain not associated with specific post-operative complication. Post-operative pain is not associated with specific post-operative complication, then it must be assigned appropriate post-operative pain code in category G89. The second case, whenever the post-operative pain is associated with specific post-operative complication. When the post-operative pain is associated with specific post-operative complication. Whenever the post-operative pain is associated with specific post-operative complications such as painful wire sutures, then assign the appropriate code found in chapter 19. T codes would be PDX followed by codes from the category. If appropriate, use additional codes from category G89 to identify acute or chronic pain. It can be G8918 or G89.28. And there are number of post-operative complications that may cause either acute or chronic pain. And the health record must be reviewed carefully to determine the cause and effect relationship. By default, you should not consider it as post-operative pain due to complication. There must be a cause and effect relationship existing between the complication and the pain. Examples of post-operative complications that might cause excessive post-operative pain are post-operative infection, which comes under the series T81.4XX. This is further expandable. Or foreign body accidentally left in body following a procedure, which comes under T81.5 series. Or complications of prosthetic devices, implants and grafts, which comes under T82, T83, T84 and 85 series. Now let us see an example. After procedure, a patient complains continuous and severe post-thoracotomy pain, and pain does not abate with medication. So the patient is sent for testing. Here, patient is having post-operative pain and it is not mentioned whether it is acute or chronic. So by default, you need to code acute form. And second case, he is not having any complication associated with it. He is just having post-operative pain. He is sent for testing to determine whether there is any complication. So as of now, for this visit, you need to code only G89.12, acute post-thoracotomy pain. Next example, a patient presents for management of painful intramuscular abscess following a procedure. Pain scale is 8 out of 10. He has been experiencing the pain since yesterday evening. So here, pain management for painful intramuscular abscess. So the first code would be T81.42XA, infection following a procedure, deep incisional surgical wound, initial encounter. Under the category T81.42XA, you will find intramuscular abscess following a procedure. For that reason, we have used this code, followed by other acute post-operative pain G89.18. Now coming to chronic pain. Chronic pain is classified to subcategory G89. One important tip is there is no time frame defining when the pain will become chronic. So we should not come to any assumptions that the pain is chronic or acute. We have to check for the physician's documentation. There is no time frame defining when the pain will become chronic. When the physician documents it as chronic pain, then you need to code chronic pain only. And the provider's documentation should be used to guide the use of these codes. The various chronic pain codes are G89.21, chronic pain due to trauma, G89.22, chronic post-thoracotomy pain, G89.28, other chronic post-procedural pain, and finally G89.29, other chronic pain. These are the 4 codes. under the category chronic pain G89.2. Now coming to neoplasm related pain. Code G89.3 is assigned to pain documented as being related, or due to cancer. It can be primary or secondary malignancy or tumor. This code is assigned regardless of whether the pain is acute or chronic. Whether the pain is acute or chronic, by default you need to code only G89.3 for neoplasm related pain. And this code may be assigned as PDX or first listed when the stated reason for admission or encounter is documented as pain control or pain management. And the underlying neoplasm should be reported as additional diagnosis. When the reason for visit is pain control, G89.3 will be PDX followed by neoplasm codes. And when the reason for admission is management of neoplasm and the pain is associated with the neoplasm, then G89.3 may be assigned as additional diagnosis. It is not necessary to assign an additional code for the site of pain. Now let us see an example. A patient presents for bone pain. Here the site is bone related to bilateral central breast cancer that metastasized. She is being treated today for pain. Here the reason for visit is pain control. So the PDX would be G89.3. Neoplasm related pain, acute or chronic. Followed by C50.111. Malignant neoplasm of central portion of right female breast. And C50.112. Malignant neoplasm of central portion of left female breast. And then cancer has metastasized and we don't know the secondary site. So C79.9, secondary malignant neoplasm of unspecified site. One important point is site of the pain is not necessary. Only G89.3 followed by neoplasm codes are necessary. Hence we are not coding additionally bone pain. Now coming to chronic pain syndrome. Central pain syndrome and chronic pain syndrome. Central pain syndrome comes under the category G89.0. This is the final code. Whereas chronic pain syndrome comes under G89.4. Are different than the term chronic pain. And therefore code should not be used when the provider has specifically documented the condition. Chronic pain syndrome and central pain syndrome are different from term chronic pain. So whenever the physician documents chronic pain syndrome, you should code only chronic pain syndrome. Additionally, chronic pain code is not necessary. Let us see an example. A patient presents for evaluation. He has been to multiple other physicians and stated that they did not understand his problem. He states that he has sleeplessness due to his pain and it is constant. He states that all the testing has been done by the other doctors have all been negative, but his pain is still present. And he states that little relief with medication. His physical exam does not match his symptomology and the patient is diagnosed with chronic pain syndrome. So the appropriate code is G89.4, chronic pain syndrome. Now here you can see the overall list of codes from the category G89. G89.0 indicates central pain syndrome or Dejerine-Roussy syndrome or myelopathic pain syndrome or thalamic pain syndrome, hyperesthetics. Whenever the physician documents any of these terms, you need to code G89.0. Then G89.11 to indicate acute pain due to trauma. G89.12 to indicate acute post-thoracotomy pain. G89.18 to indicate other acute post-procedural pain or post-operative or post-procedural pain NOS. Next is G89.21 chronic pain due to trauma. G89.22 chronic post-thoracotomy pain. G89.28 other chronic post-procedural pain and G89.29 other chronic pain. And fine, next is G89.3. Neoplasm related pain. It can be either acute or chronic. For both cases, you need to code only G89.3. Cancer associated pain, pain due to malignancy, it can be primary or secondary, and tumor associated pain. Whenever the physician documents any of these terms, you need to code G89.3. And finally, G89.4 for chronic pain syndrome. Chronic pain associated with significant psychological dysfunction. By this, we complete the coding guidelines of Chapter 6. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.